When we are approaching somebody with metastatic estrogen receptor positive disease, the issue is what type of therapy have they had before, in order to then choose the therapy for the first line metastatic disease. Some of it will depend on how symptomatic they are, how rapidly the disease came up. But basically, we have very good evidence that the CDK4/6 inhibitors in first line will extend the progression-free survival of the patients when combined with anti-estrogen therapy. So a doubling of the median progression-free survival from 10 to 20 months has been reported in the Paloma trials. And we see the same basic thing with the ribociclib trials as well. So the question is, who has to get this type of therapy? Well, so far there's no survival advantage demonstrated, and therefore I don't think we need to actually treat first line. It's not our only chance. This is just one cog in a whole sequence of treatments the patient's going to get over the next, let's say, 5 years. So I usually take the patient who has a lot of metastatic disease, has a significant tumor burden and symptoms. Those are the patients I definitely would want to treat with a CDK4/6 inhibitor upfront. The patient who had adjuvant therapy, was on adjuvant endocrine treatment, was off for a few years, has limited amounts of disease, doesn't have symptoms. Those patients really don't have to go on CDK4/6 inhibitors right away. You can treat them with single agent endocrine treatment, spare them the toxicity of CDK4/6 inhibitors, and then come in at a later date with a CDK4/6 inhibitor because we know it works in second and third line as well.